thank you, ma'am, from Evansville, Amelia, and we are talking all about implant placement today.
Mhm.
And I bet we could do this for 5 hours because I think it's one of the most common bus mob questions. We've got a ton. I tried to narrow it down front and back. But you guys can drop questions, but we have a ton of yours. And, I've got somebody who does this all day long and is happy to answer your questions. So feel free to submit them as well. But yeah, today we're going to talk mainly, the title, very professional, was over or under, choosing or changing, because I definitely want to talk about implant exchanges, implant placement with confidence, the over the under muscle question. So
Yeah.
welcome, Dr. Kate. Thank you so much.
Thanks. I'm excited. I talk about this all day, every day. So
I know you do.
it's a good topic. So
And I appreciate you taking the time. I know you have a very busy life, three kids and one on the way.
on the way.
So thank you for carving out this time because this, even for me, was one of the biggest hurdles and the most anxiety leading up to my surgery. And I've changed placement even since then. And so implant exchange is something I've always felt really passionate about because I spent so much time helping people choose their implants the first time. But then I like to be able to say, don't worry, this isn't something you're locked into for the next 60 years. This isn't a timeshare situation.
Yeah.
Like, these are not usually lifetime devices for people. And we try to be super transparent about that, specifically in Bus Mob and at Amelia.
Yeah.
And so we might as well talk about what the options are if a newer implant came out. You're not happy with your result. You want to go bigger, you want to go smaller. So, yeah, let's get into the placement conversation.
Yeah.
How do you set it up in a consultation if someone comes in first time, they have no
Yeah.
breast implants, and they're like, what do I've heard about over and I've heard about under. Explain it to me.
Yeah. I think a great place to start before you start, like, okay, which plane do I want to be in? I think is just looking at what is your lifestyle? Like, do you do CrossFit? Are you lifting? Basically, like, where do you like to live? If you're like, hey, lifting my kids and being super active, I don't want to feel implants move. That's a super important thing to know. The second thing I think is really important is just anatomy in general.
Mhm.
And then kind of the third thing is what are people like most worried about when they think about getting implants? Again, for some people, it's going to be, we can talk about, animation specifically. Some people are really worried about rippling or seeing the edge of the implant. So I think
Mhm.
some of it is before we even hash out pros and cons for each plane, it's just learning a little bit more about yourself and kind
Mhm.
of ranking those lifestyle parts and kind of where are your biggest concerns. I think me knowing that, then I can kind of guide people into, hey, I think this is going to be a better option for you versus this one. But again, before
Mhm.
people like try and know every single detail about everything, I think just generally knowing what your own goals are and what's important to
Mhm.
you is just a really good place to start.
Mhm. I think what's hard is we ask people to go get goal photos too.
Hmm.
And then you see what that person's over or under or dual placement, and you're like, well, if I like that look, I
Yeah.
want that thing. When
Hmm.
that might not at all be correct for you. I think it's one of the
Yeah.
hardest things to know from home what you might need.
Yeah. And I think goal photos are great. I really think they're great in terms of knowing do people want more of a rounded upper pole or natural upper pole. But again, like I think getting stuck on those details, you'll just kind of drive yourself crazy. So
Mhm.
I think just generally like kind of ignore even like the numbers and the profile and just like find photos that you like. Or I even tell
Mhm.
people photos that you don't like. And then I can help kind of guide you based on, just implants in general. And then plain, what's going to help you achieve that look based
Mhm.
on, again, all the things about your lifestyle and your anatomy.
And I think implant placement or implant type even
Yes.
plays into whether you should go over or under.
Yeah.
I'm old enough that I have this history of watching this decade. We went from only like under because we had
Uh-huh.
saline when I had my
Hmm.
first implants. Like over wasn't even an option. But
Yeah.
then when silicone came on the market and it could look more natural, well, then it was okay to go over. And now
Exactly.
it's really, I think women tend to look at their friends and a lot of people in this country have under.
Yep.
because of that reason. But now this swing is happening,
Yeah.
and since I now have over, I'm a little more pro over, or just
Uh-huh.
pro. It's not wrong. There's
No.
no bad or good, but I think everybody
No.
wants the best,
Yeah.
and that's impossible.
Exactly. And that's why I tell people, like, you're not going to make a wrong decision,
Mhm,
but hey, like, it's going to be different for everyone because their
mhm,
lifestyles are different. And maybe you're really worried about your, your strength training. And so you're
mhm,
not going to worry as much about rippling, where the person that comes in right after you, like, their biggest concern is rippling, right? And so then that's going
mhm,
to really play a role into what plane is best for you.
mhm. Can you give me the most common pros and cons for
Yeah,
under and then over, and then maybe even talk about whatever dual plane is? Because it sounds like
for
the
sure.
best of both worlds, but it's probably not.
Yeah, so I basically, I mean, I tell people like, hey, you're going to hear people talk about over the muscle, under the muscle, OTM, UTM. Most of the time when people talk about over the muscle, the surgeon's going to be talking about subfascial, which is meaning they're going to raise this, it's almost like a paper, very thin plane above the muscle. And they're
Mhm,
going to do that. One, it in historically is decreased capsular contracture.
mhm,
But now we have some new technology that allows for that to be decreased. But still, the subfascial plane allows to preserve some of the innate, like breast ligaments and things, to help support the implant. So there's still pros to being in this subfascial plane, but we kind of use subfascial and over the muscle. We tend to kind of use those, at least in my
mhm,
practice, kind of interchangeably.
mhm,
So then under the muscle, again, probably most surgeons are not completely under the muscle. When we say under the muscle, we're talking about a dual plane approach where
mhm,
you're at least partially raising the muscle. And that will kind of help decrease some of the risks of going under the muscle, which we talk about as animation.
mhm,
Um, but generally, just speaking in over the muscle, pros, right? We're not disrupting any muscle attachments. So people see that as a pro if they're very active. They're not going to get any animation. Basically, the implant's not going to move
mhm,
because of the muscle. So that's probably a big pro for being over. The other piece of that is, like, again, this probably the biggest con about being over the muscle is rippling. And again,
mhm,
rippling is when you can sometimes see the ripple of the implant through the skin.
mhm,
So con, I guess. I also, again, being a female surgeon, I think breast cancer surveillance is really important.
mm,
And
yeah,
even at our meetings, you'll hear surgeons kind of debate breast cancer surveillance with mammograms and things.
mhm,
If you talk to a breast radiologist, they're probably going to tell you it's easier to surveil the breast tissue if your implants are under the muscle.
mm,
But I usually tell patients there's no study that says patients with over the muscle implants have a higher risk of missing a breast cancer or late diagnosis for breast cancer. But again,
mhm,
there's some patients who, breast cancers runs very deeply in their family. That's a big concern for them is screening.
mhm,
So they may want to consider under the muscle for
mhm,
screening purposes. So again, kind of pros and cons, up and down. Under
mhm,
the muscle, again, you're going to decrease rippling because you'll have muscle
mhm,
coverage of the
mhm,
top of the implant. But again, we worry a little bit about animation. Anytime you fire your pec muscle, even in
mhm,
that dual plane where the muscle is covering the top, you're always going to get a little bit of motion. And again, for some people, that can be really bothersome.
mhm,
Um, and yeah, I mean, some of it too is the muscle. We talk about malposition and drop and fluff and all this, the muscle adds a little bit of, it's just not as certain as the implants are going to fall at the same time. Whereas when you're over the muscle and you take the muscle out of the equation, you get a little bit more predictability, probably to the implants settling into place. So
mhm,
pros and cons. Probably another one of the things we talk about is capsular contracture, which is scar tissue formation around the implant. Historically, that has been decreased if you're under the muscle, which again
mhm,
is why, 5 years ago, you talk to most plastic surgeons, and we're all doing under the muscle dual plane to decrease that risk. Subfascial, again, decreases that risk. And then with
mhm,
the arrival of some newer technology like the Motiva implants that have a kind of special shell to decrease that risk, again, we feel more comfortable going above the muscle safely and still
mhm,
really reducing that risk. So I do think there's a lot of things that have pushed this trend of over the muscle being more popular.
yeah,
But again, I still think there is a place for under the muscle. And again, it's not like there's one that's better than the other. It's
yeah,
really weighing pros and
yeah,
cons. lifestyle, anatomy, and then at the end of the day, like what your biggest concerns are. So
Yeah. What in your practice, what's like the ratio of over to under?
yeah, I tell people I'm like, again, 2 years ago I was probably 95%, under the muscle, and
Uh-huh.
really looking at my like last year, I'm probably 50-50, if not even maybe a little more subfascial over the muscle.
Wow.
Yeah.
Do you think that's mainly because of the new implants on the market?
I think some of it is, yeah, being able to say, like, hey, your risk of capsular contracture is not increased by being over the muscle. I think
Mm-hmm.
some of it is the technology of decreased rippling. So you can kind
Mm-hmm.
of offer this option to patients that
Mm-hmm.
are historically been thinner and are at higher
Mm-hmm.
risk for rippling,
Yeah.
and have been forced to go under the muscle. I also think it's just a general, like, people are more active, health
Mm-hmm.
conscious, and I have patients coming in who are like, please don't cut my muscle. I don't want my muscle cut. And
Mm-hmm.
so I think there's a little bit, all of that kind of together has played into this more trendy over the muscle subfascial placement.
Mm-hmm. I always tell people don't choose a surgery because of the recovery, because you're eventually
Exactly.
going to recover from both. Like
Yeah.
but can you tell me the main differences when it comes to recovery and over versus under? Because to some people, I get it that that's super important.
Yeah. In terms of like restrictions and things, I tell patients it's the exact same whether you're above or below the muscle. Technically a 6 week, no lifting. At 3 to 4 weeks, you're released to do a lot, light cardio, isolated strength training that doesn't involve the pec muscle. Some of that comes from the fact that, obviously if you're under the muscle, we don't want you moving your pec muscle around while the implant's kind of settling into place. But when you're over the muscle in a subfascial plane, the muscle's still part of the pocket, right? Like it's the floor now, not the ceiling. But if
Mm-hmm.
you're doing crazy exercises, you still potentially can move the implant. So I still my in my practice, the restrictions are very similar. Um, Pain is such a personal thing. I have under the muscle dual plane patients that recover just as easily as the over the muscle subfascial patients. So I
Mm-hmm.
hate to say one's easier than the other.
Mm-hmm.
Really, for breast augmentation, you can have surgery on a Thursday, Friday, and go back to desk work Monday, Tuesday, no matter which plane
Mm-hmm.
you're choosing.
Mm-hmm.
Yes, if you're not raising the muscle up, you're probably going to have, you know, less tightness, less, it's almost like less trauma.
Mm-hmm.
So there's probably a benefit, a little bit faster recovery technically for over the muscle. But again, I
Mm-hmm.
don't think that should sway, people from choosing one versus the
Yeah.
other. Because really, they're both pretty straightforward.
Yeah.
So,
How about appearance? I see this question of bus all
yeah.
the time, like Franken boob, obviously.
Yeah.
Will that happen if you go over the muscle?
So again, when I say like take the muscle out of the equation. When you
Yeah.
do that, right? Yeah, there's a little more predictability to the implant settling into the tissue a little bit faster.
Mm-hmm.
The muscle does hold the implant up, and that's why we say that drop and fluff can sometimes take a year. Sometimes
Mm-hmm.
it's happens faster on one side versus the other, and we just don't have that when you're in an over the muscle plane.
Mm-hmm.
Um, Generally speaking, though, I mean, I have seen, again, I've used a lot of the newer Motiva implants in the last year,
Mm-hmm.
but I've seen them under the muscle, and I think some of it is the less inflammatory kind of environment that implant creates.
Mm-hmm.
That even in under the muscle, when patients are using Motiva, they still have kind of this decreased swelling, maybe a little bit faster drop and fluff, and that's just me anecdotally from
Yeah.
just seeing in clinic. Um, so again, I hate to like under the muscle promise quicker
Yes.
result
Yeah.
than but um, I do think the muscle can hold that implant
Yeah.
up
Abs-
longer
yeah.
than your
It
tissue can.
it seems like it would.
Yeah.
Um, I know surgeons, and you see it all over bus bob, are all over the place when it comes to like recommendations right after surgery.
Yep.
Bra, no bra, underwire, no, sports
Yep.
bra, exercises, no.
Yeah.
Where do you stand? And like, are there big differences between what your protocol is after if you do over or under?
No, generally, some of it's just streamlining for everyone. Just in terms of stretching and that kind of stuff. I do both again for over or under, because again, muscle's still the floor. So, I think
Hmm.
that stretching is really great to kind of prevent like shoulder and back pain and stuff too. So I think
Hmm.
there's a place for it even in the subfascial over the muscle. So like,
Hmm.
we do stretches immediately after surgery. That's part of our rapid recovery protocol no matter what. Again, there's still risk of bleeding or hematoma, which,
Hmm.
it can happen in the first 3, I've even seen 4 weeks. So really around the 3-week mark is when I feel comfortable letting people kind of open up more to like a low cardio, like stationary bike. Again, I'm okay for strength exercises for lower extremity and things.
Hmm.
I just don't want that pec muscle moving a whole lot,
Hmm.
because again, we're kind of waiting for this capsule formation to start to kind of lock everything into place.
Yeah.
But generally speaking, like walking, I'm like, I want you walking right after surgery. Like, you
Hmm.
can still be active, um, but just we do still want to give time for things to settle into
Yeah.
place.
And no crazy compression
No.
or surgical,
I like
sports
light
bras.
compression. Yeah, I
Yeah.
mean, I say like a gentle compression. I think a lot of the Amelia practices use the Kubi bra, so
Hmm.
it's nothing like super tight and painful. And then
Hmm.
I really say, and even patients can really get into whatever sports bra. Everyone has their own brand or their own fabric, or
Hmm.
so really once they shower after 6 hours, they can get into whatever kind of
Hmm.
bra they want. I do think there's a place for some sort of support.
Hmm.
I say if you have an event or you want to go out one night and you want to go
Hmm.
braless, that's fine. But I think just general support, I think maybe even just for like pain control is
Hmm.
helpful. So, but
How
yeah, nothing
about
crazy.
long term? Like, first of all, I want to ask you in a
Yeah.
second, long term over under, but
Uh-huh.
I have a theory.
Yeah.
So it's funny, Kubi's,
Yeah.
it shows how often I've had surgery that I wear a Kubi every single night to sleep.
Yeah.
And I can easily go a week because I have 7 different ones. I
Hmm.
have had 7 different sets of implants, but it feels better to me now that
Hmm.
I'm over.
Yeah. Interesting.
And I don't know, I just it
Huh.
feels like good for me. I know other people don't want to. But do you think wearing a bra can help over time keep them a little higher?
Okay, so this is what I tell patients. I say there's no study that says wearing a bra every night for 10 years will decrease your droopiness or whatever, right?
Yeah.
There's not like a head, like I wore a bra on this side and I didn't wear one on
Oh
this
my
side.
God.
Here's what happened, like that, it doesn't exist. Generally speaking, support over time is probably going to be better than no support over time.
Got
But
it.
again, there's patients who are like, it drives me crazy. I can't wear a bra at night.
Yeah.
I can't
Yeah.
sleep.
Yeah.
And I'm like, okay, well, you didn't get a breast augmentation to torture yourself. So if you're miserable in a bra, don't wear a bra. But generally speaking, support more frequently, long term, is probably going to put you at a better place than no support.
Yeah. It feels better. When I was under the muscle,
Hmm.
those babies were locked in. I
Yeah.
did not ever wear a bra. And then the minute I had them over, I liked how it looked. They looked more natural, but I immediately felt the movement,
Mm-hmm.
and I prefer them to be, and but the Kubi is not tight. So yeah, for me, I am happy to sleep in a bra, and
Yeah.
plug for the Bus Mob sports bra. I have run 5 half marathons in that thing. They're
Nice.
back
Yeah.
for sale on the site. They're so awesome. I love them so much.
They are. I think you
Um,
brought one for, I think I have one.
yeah, I
Mm-hmm.
really
Yeah.
like
They're really
them.
nice. Mm-hmm.
They're not like the sexiest thing, but they function over fashion when it comes to your implants.
Yeah.
But longevity, because I've heard people talk about that for over versus
Yeah.
under, of like which will last longer. Will you have to
Mhm.
have a lift with overs,
Yeah.
and how big can you go over? Are they going to pull down? Like
Yeah.
it feels like, yeah, well, then now they're only being held in by skin. Of course,
Yeah.
that's not exactly good thing I'm not a doctor, but yeah, what do you
Well, yeah.
think?
I would say go to a meeting and listen to 2 different surgeons debate it because again,
Mm.
it's very I think dependent on a patient's tissue. You'll hear so again, here's kind of what I share with patients, right? Like you said, like when your implants are below the muscle, you may feel like they're more supported.
Hmm.
So now over time, your implant may stay higher.
Hmm.
Again, gravity is going to continue to work. So your breast tissue is going to continue to age over the top. So what we find is, 10, 15, 20 years from patients that have had implants under the muscle, they may develop what's called a waterfall or Snoopy deformity
Mm-hmm.
because their implants are kind of stable high and now their
Mm-hmm.
breasts have aged over the top of the implant. So
Mm-hmm.
still not a really pretty thing to see, right?
Mm-hmm.
Now, contrast that if your implant was over the muscle, your
Mm-hmm.
implant's going to age in your breast tissue over time.
Mm-hmm.
Now, does that mean you may notice the droopiness and the heaviness a little bit more because the implant maybe is contributing to some of that stretch? Possibly. So some of it is like, we can't really predict which one's going to happen.
Mm-hmm.
Which one again are you maybe more concerned about? It's kind of like pick your poison. Your breast is going to age no
Yep.
matter what. Yes, yeah, but it's like, is it better to have your implant age with your breast tissue and have everything kind
Mm-hmm.
of be cohesive over time? For some patients, yes, right? And then there's
Mm-hmm.
some patients who may say, oh no, I want to do everything I can to keep that implant locked where it is, but you do run the risk of your breast tissue aging over the top, and then you're going
Mm-hmm.
to want a breast lift in 15
Mm-hmm.
to 20 years.
Yep.
So again, it's not like one's better, one's going to age better. You kind of
Yeah.
have this one situation may happen or the other situation may happen.
Yeah.
So,
Do you have specific recommendations per placement with how often or how much someone might need to come back and get them redone? Like, is it about the like, or what do you recommend when it comes to that?
it would be really great. For my patients, I kind of generally leave it up to them of, usually like our final appointments around that 6 month mark.
Mm-hmm.
And then usually I say, hey, there are some patients who want to be seen on a yearly basis. Like they feel better popping in for just like a quick check in, make sure
Mm-hmm.
they don't have capsular contracture. They feel better being seen on a yearly basis. So
Mm-hmm.
basically, we kind of set them up for yearly appointments with me.
Mm-hmm.
Especially with some newer technology, it's good as a surgeon to be able to see kind
Yeah.
of implants age with patients over time. I also have patients who are like, that sounds like a waste of time. Like, I'll call you if I need you, right?
Yeah.
So, so again, everyone's going to be a little bit different. Generally, I think you should see a plastic surgeon if you have concerns, something
Mm-hmm.
changes, you don't like how something looks, then you should go be seen. So, again, am I going to start, because my practice is now trending more above the muscle, am I going to start seeing patients back sooner?
Mm-hmm.
I don't know, and
Mm-hmm.
I don't think so.
Mm-hmm.
Historically, before we all switched to dual plane under the muscle, everyone was subglandular over the muscle,
Mm-hmm.
back
Mm-hmm.
in the day. So, some of this is technology changes, techniques change. It's kind of hard to predict 10,
Yeah.
15, 20 years down the road. Um, and I think each patient's tissue is different, so their needs for revision surgeries in the future are going to be different. I think it's just hard
Yeah.
to predict.
Yeah. No, that makes sense. So when we talk about then the life of it,
Uh-huh.
implant exchange has to come into the conversation.
For sure.
And again, I said it was my favorite thing to tell people, like, it's not that big of a deal. Like, they
Yeah.
pay all this money, they go through this recovery the first time, it's anxiety, what size, what placement, what incision, all these things. And I'm like, don't worry, it will be like a tenth of everything, the mental load, because now you have an implant too. And so it was
Yeah.
very easy for me to then understand, oh, I want to go a little bit bigger or a little bit smaller. But the first time when you have nothing,
Mm-hmm.
it's so overwhelming. And
Yeah.
so, yeah, I have gotten to do it multiple times in multiple ways.
Yeah.
After kids, I changed from saline to silicone, lost some weight, started working out, decided the animation
Mm-hmm.
was not working for me at all anymore. It was doing it even when I wasn't moving. It
Yeah.
just was not, they were not round. And
Mm-hmm.
so I had to go to sleep for that one, obviously,
Yeah.
to go over the muscle. And that's where I am now. And it's great. But implant exchanges, like that probably wasn't considered an implant. Is it
Yeah.
considered an implant exchange when you change placement, or is
I
that a
do. I
revision?
No, I kind of I consider it an implant exchange. You're still, most likely you're still exchanging your implant, if
Yeah.
it's been 10 years, you're still the implant's still changing. I kind
Hmm.
of call it like an implant exchange with plane change versus
Got
just
it.
a regular implant exchange.
Got it.
But yeah, I mean, like, again, I think, people hear about this FDA 10-year implants are only good for
Hmm.
10 years. And I kind of say that with the caveat of really the FDA put that in place just so patients know it's not a lifetime device, right? Like,
Hmm.
It's not that you have an expiration thing that like ticks down. It's been 10
Mm-mm.
years, boom, 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 you have to go get
Mm-hmm.
surgery. It's just, I think, a safety thing for patients to know they may not last
Mm-hmm.
forever. But I
Mm-hmm.
tell patients you can go as long as you're not having concerns, as long as you're happy, go as
Mm-hmm.
long as you can. But
Mm-hmm.
I tell patients exactly what you said. Like, hey, exchanges are pretty straightforward,
Mm-hmm.
easy recovery. You know, again, like it's not. It ends up, it's a surgery. Yes, there's risk. We go through all that, but really, at the end of the day, it's a very straightforward. Take it out, put another one in, right? So
Mm-hmm.
um, I think they'll find that it is pretty easy to
Mm-hmm.
undergo.
Yeah.
Just to
Do you
take
do them awake, asleep? And how do you know,
it.
like, is
Yeah,
how big or small can you go?
yeah, it depends. Generally, I do pocket optimization with my exchanges, meaning I open up the pocket in the middle and I always tighten it down laterally. Over time, implants want to shift more to the side. So I think
Mm-hmm.
everyone at least gets a little bit of a pocket optimization,
Mm-hmm.
meaning I kind of shift the pocket medially
Mm-hmm.
and any opportunity that we get to go into the pocket. And
Mm-hmm.
generally, patients are more comfortable when they're asleep to numb kind of all the
Yeah.
areas up. So
Yeah.
again, that's generally my take, but I know a lot of Amelia surgeons who, just kind of pop the implant out, pop it in, and that is
Yeah.
very easily done while you're
Yeah.
awake under some numbing medicine. When patients come in to see me for an exchange, usually my first question is, do you like where your implants are now? Like kind of you said, you're like, oh, I'm super bothered by
Mm-hmm.
the animation. Like if someone comes in and they're like, hey, I just want to be bigger. Hey, I just want to be smaller.
Mm-hmm.
Generally, I have no other concerns. You don't necessarily need to consider a plane change, right?
Mm-hmm.
It's usually the patients who come in that are like, oh yeah, for the last 5 years, my implants fall into my back and it drives me crazy. Or
Mm-hmm.
I'm super active now and the animation is drives me crazy. Or man, the rippling with these saline implants, like I want to go under the muscle, right? So
Mm-hmm.
generally, if you're like, yeah, I'm happy, I just want a size change, or I want to try the new Motiva implants, or
Mm-hmm.
right, then I said, don't rock the boat. If you're happy where you are, keep them there.
Yeah. Yeah.
It's if there's these other things that bother you or they drive you crazy, it's potentially an opportunity to discuss plane change at that
Yeah.
time.
Is it considered a revision when it's like painful or there's like an issue? I know women don't, I see it often in Boss Mom, like, is it a revision or is it an implant exchange? I don't even know what to request to talk about. And I know you guys figure it out at the consultation,
Yeah.
but is there a surgeon way you filter one over the other?
Yeah, I think again, like basically anytime you're having a secondary breast surgery, it's probably under an umbrella of revision.
Hmm.
And then under
Hmm.
revision is maybe implant exchange, breast lift, mesh. Like, there's probably just like a general category of it's a revision because I've had a
Hmm.
surgery before on my breast.
Hmm.
So probably in my mind, that's how I consider it. Like,
Yeah.
I'm typing my note out and the heading is breast revision, or
Yeah. Yeah.
but
Yeah.
really
Yeah.
like I think if somebody comes in an implant exchange, it's a revision because they've had a surgery before.
Yeah.
I think it's semantics, but
We need to like,
it
yeah, call them something. I'm trying to think of like a car analogy, like a
yeah,
trade in, or
yeah,
I'm
yeah,
like
yes,
upgrade. We're
yeah,
upgrading somehow.
yeah. Because again, generally, like if you're there for a concern, but it's been 15 years, you're probably
Yeah,
exchanging your implant. So it's like, it's kind of
yeah.
all the
We're
same.
getting new tires on the car. I need to stop. Obviously, I'm buying a car recently. I had a question about placement change because I
Yeah,
think I see a lot of people sometimes like, well, if I'm going under to over, do they tack down my muscle? Does my
yeah.
muscle like what has to happen both ways internally? And like, is the recovery harder going one way to another? Or
Yeah. So I'll tell you, so from under to over, right?
uh-huh.
We're gonna take your implant out from under the muscle.
Hmm.
I am gonna put your muscle back down. I'm gonna tack it down onto your chest wall. And
Hmm.
basically I kind of reset where the original muscle was before. Kind of like
Mm.
put it back down, right?
Hmm.
Some of that is because if you don't, and you just kind of start to create a plane over the top, what can happen is your muscle is not secure, so your muscle can actually kind of almost like window shade and start to pull up. So not
Mm.
only may you still get some animation, you may also see like fullness at the top.
Mm. Hmm.
So it kind of prevents this window shading of the muscle.
Hmm.
And it actually, as from a technical standpoint, makes your plane, like your subfascial plane creation a little bit easier because I've
Mm-hmm.
got tension now. So really that's the first thing. Pop the implant out, put your muscle back down, and then you just create, it's like a brand new pocket. So again, when
Mm-hmm.
patients have issues with their implants sliding all over the place or they're double bubble and their muscle's super high, and it's again, I just say let's take the muscle out of the equation, let's put
Mm-hmm.
it back where it wants to be, and let's start completely fresh in a new plane. So
Mm-hmm.
that can be a really great option. If you're going and it doesn't require a drain. I think that's other people's
Okay.
biggest question too.
Yeah.
No
Yeah. Yeah.
drain, at least again
Okay.
in my practice,
Mm-hmm.
you have to worry about that. If you're going over the muscle to under the muscle, it can be a little bit kind of trickier. I usually like to use mesh in that
Mm-hmm.
case because you can imagine most people are dual plane. So, your muscle's sitting up here. And
Mm-hmm.
so there's some, I think some surgeons who keep your previous capsule and use that to kind of lock the bottom down. But, your implant's sitting on top. Now we take it out. You've got the space above it. Now I'm
Mm-hmm.
going to raise another plane underneath to put your implant in. I don't want it to flip
Yeah.
back out.
Yeah. Yeah.
So again, once I create the new plane under the muscle, I'll usually take some mesh and tack it to the bottom and then
Got it.
tack it down to create a little sling.
Yeah.
So
I've definitely seen
yeah,
people say that in bus mob too. Like
yeah,
my implant moved from under to over.
yeah. And sometimes that happens in dual, like sometimes with dual plane, like I've kind of seen that. And I think
Mm-hmm.
maybe that has to do with how their pocket was originally created. So yeah, I mean, I think when you go over to under the muscle, like I tend to have a conversation of, hey, this may involve mesh just to really lock things into place.
Mm-hmm.
And again, it's
Can you?
probably more trendy now to go under to over.
Yeah.
Yeah. So
What
yeah,
I was going to ask you about MASH. Can you just give a
yeah,
quick overview of what that is and how surgeons use it? Because it comes up a lot, and I think
yeah,
people are confused, kind of.
yeah.
I'm confused sometimes.
Yeah, and again, you can talk to multiple different surgeons, and you may hear multiple different
Mhm.
things. I think I'm generally kind of in the middle, like in terms of like how I feel about mesh. I probably
Mhm.
represent middle of the ground I feeling of it. But basically, mesh is there's a couple different brands you may hear people talk about, but generally it's a non-permanent, lattice of what's equivalent to like a suture material. So it's almost like a hammock material. And the
Mhm.
idea is that it's going to go in and support breast tissue or an implant, create collagen and scar tissue over time. The mesh is going to disappear, but it's going to leave behind strength. So
Mhm.
you're going to have different materials based on different companies. I like Galaflex mesh.
Mhm.
Again, it lasts about 12 to 18 months, and breaks down into water molecules. Very low risk. Added costs and things, but
Mhm.
generally it can be used just to add support. And so people call it an
Mhm.
internal bra. You'll hear people say that a lot.
Yeah.
And it's not. Yeah, I mean it's great. I don't think everyone needs it. I think there's certain anatomy types like breast tissue types, patients that have had massive weight loss, patients that are
Mhm.
doing a super high volume implant over the muscle, people that are doing a higher volume implant over the muscle and want to do a breast lift. Like I think there's certain times where mesh is really helpful.
Mhm.
There's certain people that are like, hey, I want to do everything to get longevity to my implant staying up as high as I can get it.
Mhm.
Mesh is a really good, thing to add if that's
Mhm.
something that's important to you. You'll hear surgeons say any implant over the muscle should have mesh. Again, I don't know that I'm in that camp,
Yeah.
but there's some surgeons who may think that. Um, I think it's good for certain patients, and I think sometimes
Mhm.
it's unnecessary in others.
Yeah.
I do tell
One.
patients it's considered off-label use by the FDA. So
Oh, okay.
um, it's been approved for use in the body, like the Galaflex mesh I use
Uh-huh.
has a different name when it's used in the abdomen for hernia repairs.
Mm.
So it's super, super safe. It's been around for use in breasts. The company just hasn't paid the money to get
Mhm.
the specific breast research or, to have it covered.
Mhm.
But again, I think that's something to be transparent about with
Mhm.
patients. So,
Is
yeah.
there? I know there's an extra cost to it. I
Mhm.
had it at with one of I think with one of my capsular contracture surgeries.
Yeah.
And I was surprised that it added some recovery in a way. And like I could feel it
Yeah.
for a little while. And I just like I didn't expect that
Yeah.
necessarily. And like it didn't bother me, but like I could feel it for months. It
Yep.
just felt like there was like something in there,
Yeah.
like a little crinkly or something.
For sure.
It
Yeah. Kind of like
was strange.
tissue paper or something. Yeah.
Yeah,
And that's,
yeah.
yeah. And that's, again, that's kind of why we tell people it takes some time to break down. So
Hmm.
while it's breaking down, you may feel it, and it tends to
Hmm.
be in the lower pole of the breast because you can use it like a hammock.
Hmm.
And so, yeah, it's not something that hurts you. It's not usually something you see, but it's definitely something that you could feel.
Hmm.
And yeah, it can take a year, sometimes over a year for it
Hmm.
to kind of go away. And there's some people who, 3, 4 years, they may feel where the collagen kind of replace. I've even
Hmm.
heard people who are very thin sometimes feel that
Hmm.
tissue thickness. I've gone back in to see, just, happen to see
Hmm.
where previous mesh has been used. And I think because
Hmm.
there's some people that say it really doesn't do anything, but you can see where previous mesh has been placed. The capsule looks different, is a little bit thicker. There's a little bit of strength to that area that really does last longer than the
Hmm.
mesh is there for. So
That's really cool.
yeah,
This is wild what is available now. Like
yeah,
in some ways, I wish I had my first time primary augmentation now versus 20 years ago, but it's just
yeah,
wild what is
yeah.
available.
I think it's great. I think,
Yeah.
5, 10 years we'll have newer technology too. I think to keep advancing is really great. So,
Yeah. Cycling all the way back to the beginning, if somebody has not had implants and they come in for consultation, and this is something like in Boss Mob, it can get overwhelming. Like the
hmm
community is like, if you are considering either an implant exchange or just even don't even know what placement is or things like that, Boss Mob is the place for it because it seems like one of the most common topics. But is that something you will help like guide? I think the
yes.
biggest fear is someone's like, well, you give them all the information, but then you don't make any recommendations.
Yeah.
And like I personally am like the one I want someone to recommend, given all the things
Yeah.
I've said. Now tell
Yeah.
me, is that kind of how it works?
Yeah. Generally, so like my consult starts where it's just like hey, let's go through your goals. Let's look at your photos. Again, let me learn
Hmm.
about your lifestyle. Let me learn about what's important to you, what your concerns are. I'm starting to already kind of think, I haven't even seen your anatomy yet, but I'm already kind of starting to come up with like a general plan. For some people, it's right away like super active CrossFit doesn't want animation
Hmm.
over the muscle, right? There's some people who kind of like, oh, okay, I could see him going either way. Some people who are like, I'm terrified of like if I have rippling, I'm gonna be, and it's like under the muscle, right? So I'm already starting to kind of help guide them just based on hearing who they are and what they care about, right?
Hmm.
Then we get to the exam, and there's some people whose breast tissue, like that just sits a little bit lower. They
Hmm.
have maybe a little bit more of a natural kind of droop, what we call ptosis to their breast, and they're
Hmm.
looking for a natural result. Those kinds of clues, I'm already cluing in like a subfascial over the muscle implant's going to
Hmm.
settle really nicely and predictably into that breast tissue. They're wanting a more natural result. It's like for me, I'm already starting to put the pieces together. And
Hmm.
then usually at the end, we start looking about implants and it's kind of like, hey, based on XYZ, the
Hmm.
risks, the pros and cons, I think a subfascial approach over the muscle is going to get you there, with minimal risk and help you,
Hmm.
achieve these goals, right?
Yeah.
There's some people who I say both are great options. At the end of the
Hmm.
day, you can't go wrong with either one. What are you
Hmm.
most concerned about? Let's use
Yeah.
that to kind of help figure out over the muscle or under the muscle.
Yeah.
And then
And
again,
I
there's
do
some
think,
people on like under the muscle, like we can't do over the
yeah,
muscle, terrible idea. So
yeah. I
yeah,
do think getting in Best Mob and figuring out what that most important thing to
yeah,
you is, like, I wouldn't have known those things, I'm
yeah,
like, oh, rippling, oh, this, oh, safety, oh, rupture,
yeah,
there's so much to think about.
yeah.
But yeah, I always tell people, like, would this keep you up? What would keep you up at night?
Exactly. Especially with
Or be
size.
like, I
Yeah,
wish I wouldn't have done this. Like, I have rippling, I don't care.
yeah,
I'm
yeah,
not showing them to anybody
yeah,
but my husband, and he doesn't care.
yeah,
But other people are so upset about that. Like, I think
yeah.
there's so many examples like that.
Yeah, and that's what, yeah, people are like, well, which one should I choose? Which one's the best? And it's like,
Yeah.
well, hey, if that was the answer, we wouldn't be, they'd be so easy
Yeah.
because I'd be like, do this one. I only do this one, right? Like there's not one perfect path, but
Hmm.
that's also great because it's so customizable for
Hmm.
everyone. Like, and that's
Hmm.
that's like the great part about it. So,
Yeah. I just got a good question that I don't quite know the answer to, but I've heard this too.
okay.
Does going under the muscle change the appearance of the size of the
Mm.
implant. Like I've always heard that you kind of almost like lose 100 cc. I mean, I don't remember what the thing I've seen if you go under because it's being pressed down more, by
Yeah.
your muscle. Like, so do you have to do a little math there to like get the
Yeah.
size?
There's you could put pictures up probably and like blind, and you'd be like, yep, under the muscle, over the muscle, and then there's people that are kind of in between who have a very rounded look, and you're like, for sure
Hmm.
that's over the muscle, and they're under the muscle.
Hmm.
I think it has to do again with everyone's anatomy. Like if you have a really thick muscle, right?
Hmm.
Yeah, that maybe is going to be stronger and push the implant down more.
Hmm.
So again, I generally don't let placement of like which plane we're going to go to affect the implant volume because I think
Got
at
it.
the end of the day, it's probably so negligible that you'll drive yourself crazy trying to like
Hmm.
sit there and do a math equation, to feel like, oh, I'm going under the muscle, so like maybe I should add back 100 or
Hmm.
I think at the end of the day, it really doesn't make a huge difference. What
Hmm.
I will say, there's some patients who are really worried about a step off at the top of the breast, right? Like
Hmm.
feeling like they can see the edge of the implant and have a huge step off.
Hmm.
Sometimes when patients bring that up, if they are very thin, I do think that's where the muscle can kind of help soften that transition. So if
Hmm.
you're kind of in between where you like really want a rounded result, but you also kind of want a little bit of that teardrop,
Hmm.
potentially the muscle can provide some of that protection from that major step off.
Hmm.
So I probably think of that more than a volume
Yeah.
change. Yeah.
Oh my God, that like just knowing all I have to do is go in and know
Yeah.
what's important to me.
Yeah.
Like it is so cool that these days we have so many options, but it
Yeah.
it can be too overwhelming because God,
For
we
sure.
didn't even talk about profiles
Yeah.
and BWD and all the things that women can try. Like we want to be in charge of our own healthcare,
Yeah.
and help, but at the same time, we aren't the experts.
Yeah.
And so knowing that if we have these concerns and these wants and with a picture, people help us
Yeah.
figure out a plan, I do think we need to trust,
Yeah.
go in with some knowledge and be able to advocate for ourselves, but also know you guys see it 10
Yeah.
times a day and we don't.
Yeah. And I think like this evolution of like what plane do you want to be in, it happens kind of during the consult. Like again, I think if
Hmm.
you come in and you're like, oh no, what am I going to choose? I think just kind of letting it happen kind of naturally
Hmm.
and organically through the consult time. Because
Hmm.
again, it's like there's so many of these little pieces that help kind of guide which option's best for you. We just kind of let that happen. And at the end of the consult, it becomes pretty clear like, hey, this is which direction I'm leaning
Hmm.
versus this. So,
Yeah.
yeah, it
Well,
doesn't have to be
you
stressful.
have made me feel more confident in it. So I know you have made others lots of good comments and questions. I appreciate you taking this time. Now I get
Yeah.
to ask you really fast. I saw your picture from your Amelia Island trip, which I thought
Mhm.
was so funny with Amelia Aesthetics. How was
Yeah.
it? Was it fabulous?
It was amazing. And yeah, for like people that don't know, all the Amelia surgeons got together with their families and spent some time on the beach. The surgeons kind of got together and talked about technique and just, building great patient experiences. And our families got to meet. It was really a wonderful, wonderful experience. So, yeah.
It looked like the kids might have had a better time than you
Oh,
guys
yeah.
did.
My kids are all over the place. My 18-month-old was like a hot mess most of the time, but it in
All right.
great company because really a lot of the surgeons' kids are around the same age. So
Yeah,
yeah, it was
that's so
it was
cool.
fun. Yeah.
Thank you guys for continuing to hone your craft
Oh yes.
with us in mind. We appreciate you from the Bus Mom community so much. And if you do have questions, obviously you can reach out to Dr. Kate anytime on Instagram, through the askamelia.com website, in Ask a Surgeon and Bus Mom. But also, I think the Bus Mom community is a great place to get in there and start asking questions if you're new to this and trying to figure out placement. But I think this is a great overall understanding of what it is and what it isn't. So
Awesome.
thank
Well,
you.
thank you. This was great.
Good. I'll see you soon. Now go home to all
Okay.
your babies.
Yep. All right. Thanks.
Bye, everybody. Thank
Bye.
you.